which ones you choose, and also about what kind of procedure you're going to do. So I'm going to go with mostly basic procedures like a suturing or something where you would use infiltrate a local anesthetic. Okay. So when you look at the skin, where we're trying to get the drug is down to the subcutaneous space. So about how far down is that? Any idea? Pardon?
All the way down.
About half an inch or so. Okay, so how many millimeters is that? 5 millimeters?
Yeah.
How many millimeters in an inch?
2.5.
25. Okay, so about 12. Okay, so the hypodermis or subcutaneous fat, that's where we're going to try to get these drugs. All right. So the way they work is they are going to, they're deadening what? What are we trying to deaden? Intervene. Pain. Okay. So what we're going to do is we're going to affect neurons. What in the neuron are we going to try to affect? Well, what creates pain? How do you know you've got pain? Okay, so the nerves work, we have those action potentials, remember them?
Yeah.
Okay, so the way we can decrease transmission of pain is we can change how those sodium channels work. Okay, so let's look at we've got this. So we're going to look at those sodium channels that allow the movement of sodium in and out. Why is sodium would be the particular target?
That's where the action potential starts.
Okay, so it's the actively keeping that sodium and keeping a concentration difference or a voltage difference across that membrane that allows an action potential to occur, right? What's the voltage difference between an in and out?
0 to minus 60.
It's about 70. Okay. And it's the movement in, what do we call that when that sodium starts pouring in? What is that? Depolarization? Okay. Depolarization means what? It's giving more positive, right? So we keep that difference negative, and as it moves more positive, it means more of those sodium ions are moving into the cell. So I pulled one of the Khan Academy. We're going to watch just a little bit of this. It's about 10 minutes, but we're going to watch maybe the first 4 or 5 minutes. Are you all hot in here?
Yeah.
Yes.
In this video, I want to talk about how action potentials are generated at the trigger zone and how they're conducted down the axon. So I've drawn a soma here in red and one axon in green, and I've blown up the axon to a very large size, just so I have some room to draw. Here's our graph of the membrane potential on the y-axis and time on the x-axis. And now I've put a couple of different kinds of ion channels in the membrane of the axon. The first, in this lighter gray, are the leak channels that we talked about when we talked about the neuron resting potential. These channels are open all the time. They're not gated. And I have not drawn any ligand-gated ion channels like the neurotransmitter receptors that occur on the soma and the dendrites. But to talk about the action potential, I need to introduce an entirely new type of channel that I've drawn in dark gray with this little V, and these are voltage-gated ion channels. The membrane of an axon has many voltage-gated ion channels, most of which open when the membrane potential crosses a threshold value. So we talked about the threshold potential before, and all of these numbers may vary between different types of neurons, but these would be fairly common values. So many neurons would have a resting membrane potential of around negative 60 millivolts and a threshold potential of around negative 50 millivolts or so that I've drawn with a dashed line. And the importance of this threshold potential is that it determines if these voltage-gated ion channels will open. So when there is enough temporal and spatial summation of excitatory graded potentials to get us toward the threshold, here at the trigger zone, at the initial segment of the axon. So let me just draw that we have temporal and spatial summation of excitatory potentials spreading across the membrane of the soma into the initial segment of the axon, the trigger zone. This voltage-gated ion channel has a mechanism to sense this voltage change, and when the threshold potential is crossed, it's going to open, and these are going to be sodium channels. Recall that the electrical and diffusion forces acting on sodium ions are strongly trying to drive them into the neuron. So when this voltage-gated sodium channel opens, sodium is going to flow into the neuron through the open channel, causing that part of the membrane to depolarize from all these positive charges now on the inside. This is going to cause an explosive chain reaction by triggering the voltage-gated sodium channels in the next piece of the membrane. So that more sodium is going to flow in, further depolarizing the membrane and opening the next voltage-gated sodium channel. These voltage-gated sodium channels open very quickly, triggering each other in a wave that rapidly spreads down the axon. The trigger zone has the greatest density of these voltage-gated sodium channels, which is why action potentials usually start at the trigger zone. So many of these voltage-gated sodium channels will open that the membrane permeability to sodium is dramatically increased. This is going to cause the membrane potential, which has already gone from the resting potential to the threshold potential from the graded potentials. But now that all this sodium is flowing in through these open channels, the membrane potential is going to dramatically rise, trying to head toward the equilibrium potential of sodium, which is usually somewhere around positive 50 millivolts. This rapid increase in the membrane potential values is due to these voltage-gated sodium channels. And this is called the rising phase of the action potential. And in fact, it becomes more positive inside the neuron membrane during this period. That is the reverse of the resting potential, because normally it's more negative inside than outside the neuron membrane. But now so much sodium has entered that it's more positive inside the membrane than outside. The action potential usually peaks, though, somewhere around positive 40 millivolts. So it doesn't make it up to the sodium equilibrium potential that's often around positive 50 millivolts. And the reason for that is that these voltage-gated sodium channels automatically start to close at the higher potential values so that sodium stops flowing into the neuron. And after they close, they're in a special state called the inactivated state, and they're unable to open at any membrane potential for a brief time. The next thing we see happen to the action potential, basically just as fast as the membrane potential went from the resting potential to the peak of the action potential, it then rapidly descends back toward the resting potential, and then actually goes farther. It goes more negative than the resting potential, and then it levels off. The reason for this part of the action potential, which is called the falling phase, is because potassium starts to exit the neuron, and it does so through a couple of types of channels. The first are the leak channels that we talked about when we talked about the resting membrane potential. Now, a little potassium is exiting through the leak channels at the resting potential, but even more potassium than normal starts to exit, because during these parts of the action potential, the membrane potential is positive, so that during this part of the action potential, both the diffusion force and the electrical force are strongly trying to drive potassium out of the.
Okay, so you can listen to that or review it again. I have also given you another one that is really good. It's more animated, so if you really like a different view or type, his explanation is good. The other one gives you a more visual that might appeal to some of you, so it's there as well for you. Okay. So let's look at mechanisms of action. We talked about the sodium channel and blocking that so you interrupt the transmission of action potentials. But it also varies, or the action is going to be dependent on the type of fiber affected. Okay? So remember, your fibers are different. So in those peripheral neurons, you've got many different types of fibers, and 3 of them are shown here. Some of them transmit pain, some of them transmit other types of sensations. So we'll look in just a moment is that the rapidity at which those sensations go away or return are based on the type of fibers you're affecting. Myelinated fibers are faster or slower? Faster. Okay. And so we will affect them differently with our topical anesthetics compared to those like those C fibers. So C fibers tend to carry a more chronic pain, and they're slower in their response. Those alpha deltas, which are in the middle, are ones that usually are going to carry more acute or sharp pain, like you're going to inflict on the person when you are doing some kind of procedure to them. And so we can affect those fibers pretty quickly. So the type of sensation you're trying to obliterate or knock out for a period of time is going to depend on which fibers you are targeting. This is another slide that just kind of shows you in terms of fastest to slowest in terms of onset, and fastest to slowest in terms of recovery with the different fibers. So you see that that alpha delta is one of the fastest ones that's affected, so that's good. You've had topical anesthetics before, most of you? Okay, so effects on numbing you, fast or slow? Usually pretty fast. You can still feel touch, still feel heat and cold, but pain is usually knocked out pretty fast, and that's because we're going after those deltas. And you see that in terms of recovery, they're a little bit slow, which is good, gives you time, right? Person can get home, get comfortable, and then it starts wearing off, and then you've provided or made some other arrangements to cover pain, right? Okay. So if you look, so we talked about the sodium channels, we talked about myelinated versus unmyelinated. Fiber type makes a difference. Recovery then is usually in the reverse order of onset. Varying size of the fiber, firing rate of the fiber. The C fibers tend to be slow fibers. That's why they're affected least or less than your myelinated fibers. All play a difference in terms of the effects of these drugs. Let's talk about classification. So we classify them based on their chemical structures. There's amides and there are esters. Most of the time what you're going to use when you use a topical is going to be the amides. They're better tolerated. Lidocaine is probably the most common in that group. That group really differs in terms of onset and how long they hang around. So we're going to talk about what factors in that class will make a difference, because it will change your selection based on what you want to do and how long you have to do it and how long you want or fast you want recovery. The esters are not used as often. They can be an alternative if people have a severe allergic reaction to the amides, then you can use the esters. But the amides group is usually going to be more likely to be used. So let's look at factors that affect potency. Lipid solubility. What is lipid solubility? What is that? What are we talking about? How easy it is to dissolve a lipid in water. What does that mean to when you're going to inject somebody? How does that play out?
How quickly it works.
How fast it goes through a cell membrane, right? So cell membranes look like what? They have lipophilic and then they have hydrophobic or hydrophilic in the middle, right? So you've got to have a substance that can traverse a lipid bilayer. can get through a layer that's more smooth water and move into the cell and exert an effect. So those that are most lipid are going to have the easiest time in getting through. There's another one. I'm not going to show you this one, but I pulled it out because it looks at axon diameter and myelination on the effects of pain and also drug effect. So there's your lipid membrane. You've got gases which easily dissolve and go and traverse a membrane. Those hydrophobic, like benzene, is going to be your more lipophilic. So you can see it moves through pretty quickly. Small molecules also can move even if they're polar. But your large polar, like glucose, how do we get glucose across that cell membrane? We have transporters. We have a receptor that interacts with a hormone, right, that directs transporters to come up to the cell membrane, hook onto that glucose, and drag it in. Charged molecules have more trouble. So sodium and potassium, they're all, so we have different receptors, right? We have those voltage receptors, we have ligand receptors, we have all kinds of receptors that can, or channels, that can direct them across. Okay. So lipophilic is going to be important. So bupivacaine is one of the agents in that group. It's probably the most long-acting. It's much more potent than lidocaine. It tends to move in. It's very lipophilic, so it will tend to move into a cell very, very easily. Speed of onset, so how fast? So the other thing that you can see from this is that the less charged a molecule is, the faster it will go through, right? So these drugs are weak acids, or they're actually weak bases, and we stick a salt on them and make them weak acids. What is a weak acid? What is an acid? Proton donor. I heard somebody say it. So acids are substances that will give up a hydrogen ion, right? So a weak acid is one that doesn't like to give it up very, very fast, very easily, more stingy. They hang on to it. Okay. So these are weak acids. If we can keep them unionized, non-charged, they'll go through the cell membrane fairly easily. Here's a picture. So that HA is the unionized form, and you see it goes through that cell membrane, easily dissociates on either side. The dissociated form will not go through. It's too charged, probably too big, and more polarized, so it won't move through. So if we can keep it, the more we can keep it in that unionized form, the better. So sometimes people use sodium bicarb in order to elevate or keep the pH up so that the drug will stay in an unionized form and move more quickly. So that you can get, so you're not just standing there all day going, okay, I injected you, when can I, do whatever I'm going to do to you. Okay? So that's another property. This shows you, let's see. So what this does is it's looking at that acid and its dissociation, it's in equilibrium, and it shows you at different pHs it makes a difference in terms of the equilibrium between the unionized and ionized form. If you're adding a base, look at what happens. You're at a pH of 7.4 or a tissue pH. What form is it staying in? Look at where the dark arrow is going. Staying in the unionized form. That's where we want it. So that's the reason why sometimes sodium bicarb is added in order to increase that speed of onset. Make sense? Sleight of injection. So onset depends somewhat on distance, how far away from where you are going to do the work are you injecting them? Okay, so if it's very local and you're able to put it right around the site of where you want to do a procedure, then it doesn't take very long. Brachial plexus blocks take much longer because of the movement of the drug to that area. So you see there it's about 20 to 30 minutes. Most of the time you're talking about under 5 minutes. If you look at the very last page, there is a chart that shows you onset. This one says about 10 minutes for lidocaine. Other sources have listed as short as 2 to 5 minutes. Some of it will go to strength that you're using, amount, and what fibers you're trying to affect. Duration of action, again, very wide. Your short actings are more your ester forms, which we don't use as often. Your intermediate are like lidocaine and monoamine. Long acting is that bupivacaine, Marcaine. They're more lipid soluble, hangs around a whole lot longer, more potent. Differential blockade, again, what sensations are lost first and what recovers. So sympathetic function lost first. Loss of sensation to sharp, pain, temperature, and pressure are second. And motor function usually typically lost last, or avoided, or we avoid trying to lose that at all. Questions about those? So sometimes we add things to a product in order to change its absorption or its onset. So epinephrine is probably one of the most common ones that is used. So what is epinephrine? It's a catecholamine. Where does it come from? Adrenal what? Medulla. And it affects what type of receptors? Pardon? Adrenergic, okay, and what are they? What kind? Name them. So beta, does it affect beta 1 or beta 2? Both. Alpha? Alpha 1. Okay, so if you stimulate, are they agonists or antagonists? They're agonists, which means they do what? They cause a receptor to do, or cause a cell to do whatever it's designed to do. So if we have an agonist that sits on an alpha receptor, and let's say it's on a blood vessel, what's going to happen? Vasoconstriction. Okay. Does that not make sense why we might use it with these products? We want to keep the drug where we put it. Okay. Doesn't leak and get absorbed. Because these drugs can get absorbed. So think about lidocaine is what? Where else did we talk about lidocaine? The what?
In the throat, mouth area.
Okay. What do we use? What kind of drug is lidocaine? How do we classify it? Okay, in cardiology, where did we talk about it? Oh, come on. You're not that tired, are you? Is it too hot? Lidocaine. What is lidocaine? Oh, come on. It's an antiarrhythmic, right? Yes. Yes. Oh, come on. Come on. Lidocaine. Antiarrhythmic. I'm not even going to ask what class because I think we're not there. Okay. So, not a 3. Not a 3. So if it's an antiarrhythmic and you are giving it to someone and they can absorb it, then what are you worried about?
Arrhythmias.
Arrhythmias. Okay, and that can happen. CNS actions can also happen. So we would like to keep the drug where we want it to do its local action instead of getting absorbed and exerting toxic effects, and it can do that. All right. So that's why we use epinephrine. Have you seen those designations of 1 to 200,000 or 1 to 400,000?
Yeah.
We've seen it a couple of times, it's just not very familiar. What does that mean?
The concentration of drug.
It's a concentration. Okay. 1 to 200,000. One what in 200,000 what? It's a solution, so what are most solutions going to be in terms of their units?
Milligram per milliliter.
Usually it's so it can be a weight volume. Okay. So it's 1 gram in 200,000 milliliters. Concentrated or dilute? Very dilute. Okay, very small. Okay. So this is like 1,000 milligrams in 200,000 milliliters gives us what? 1 milligram in 200 mils, right? Okay. Percents are usually grams per 100 mils. So here we have 1,000 micrograms in 200 mils. Right? So we have 10 micrograms in 2 mils. Okay, so we got 5 micrograms in a mil. So very, very dilute, very low concentration, very powerful. So see how we got to that? So we bring, we're gonna see. Just follow your units down.
Dr. Lepassi,
Yeah.
Is the 200,000 the lidocaine, or is it a different?
It's the liquid.
Of
Oh,
what?
this is epinephrine.
And
This is
what's the 200,000
mils.
of what? I guess is what.
Diluent,
Okay,
water.
just whatever it comes to.
Yeah.
Okay.
Yes. Right. Okay. So anyway, this ends up being about, or it is, about 0.005%. So very, very dilute. Your epinephrine is always going to come in that 1 to 1,000 or 1 to 10,000 because it's such a small percent. Okay, so just, I'm not going to ask you to know that, I just want you to be aware of what it is and what it means. So 400,000, very, very dilute. So if it has, so that's alpha effects. If it has beta effects, what are those? It does have beta effects, so if it gets out, it gets absorbed. So people can have side effects from the epinephrine that you also are injecting. So the beta-1 is going to affect what? Heart rate, very good. And what will it do? I sit on a beta receptor with epinephrine, and what will it do?
Increase heart rate.
What happens to peripheral resistance with the beta-2? Okay, so you got beta-2. Where are the beta-2s? Lungs, so what effect would you expect to get there? So you get bronchodilation. So where the alpha-1s sit and where the beta-1s sit will determine what the blood pressure is. So the alpha-1s are in blood vessels. The beta-2s tend to be in blood vessels and skeletal muscles. So it depends on which one is predominant as to what happens to blood pressure. So blood pressure can go up, and it also depends on amount. So at lower levels, you get an alpha-1. As the amount went up, you could get more preferential beta effect. Okay. So you can see a gamut. Depends on how much they absorb. So can't see vasoconstriction, good, that's what we would like. We'd like it around. They get more systemic absorption. You could see bronchodilation. could see tachycardia, could see blood pressure go down. Hopefully you see none of that because we're given a really small amount and we're hoping it will just stay where we put it. Sodium bicarb, so recognize why that is there. One is to speed up the onset of action because we're keeping it in an unionized form, and so we're getting it to go into the nerve faster. Some folks also use dexamethasone as a way to affect the use of the anesthetic. There have been studies, and I put it in there in terms of prolonging nerve blocks. So it's not affecting onset, it's affecting how long it stays that way. So it has been shown for brachial plexus blocks, sciatic nerve blocks, and saphenous nerve blocks to prolong the effect. In terms of dose, seems like 4 to 5 milligrams is what most studies report. Do you see that used very often?
No, we used it more for inflammation and pain, but not so much as local anesthetic. Do you still use bicarb a lot as far as?
I don't know. I would toss that back to you. Do you ever see them use it or add it?
More as far as to help with the burning sensation of that,
Well, you can do that too.
but not so much as to change the pH. So just think of it that way.
Not to change onset, you mean? Is that what you mean?
Right.
Okay. So, yes, you can use it for burning because the pH of those is much lower than tissue pH, so it will burn. They're a pH of about 4, tissue pH is 6.8, so that burning is partly due to the difference, pH differential. Okay. So let's look a little bit at lidocaine. Comes in several strengths. Mostly it is used as the 1% solution is usually what is used. Again, sodium bicarb can be used to decrease the pain of injection. Lidocaine can be used with epinephrine, so they're compatible. The dose is important. I've seen two different things. I went with the lower one. In terms of lidocaine without epinephrine, the dose is 4 milligrams per kilo with a max of 300. Epinephrine, the dose is higher. It's 7 milligrams per kilo with a max of 500. So the takeaway is that if you're using with epinephrine, it requires a higher dose, and max doses are in effect. Do you usually go with the standard dose or standard volume? Probably a standard volume.
It's just the volume according to the size, and then
The size of what what you're working on. Okay.
and the location too, because there's certain areas of the body that clear it out faster than others, and are harder to numb up, such as the feet. Very, very hard, very painful, and it clears out really fast.
In kids, the recommendation is 80% of the maximum.
They clear it faster than adults.
Liver and kidney, and that's probably one of the reasons why kids may clear it faster, is their kidney function is a little bit better. But liver and kidney are a part of the getting rid of those drugs. So in elderly patients or people who have liver or renal dysfunction, lower the dose. Onset of action, 2 to 5 minutes was the fastest I found. Duration is about 30 minutes to 2 hours. The next bullet there is pretty much a repetition of what we've already talked about. Should avoid it when you're using digital anesthesia. especially if people have peripheral artery disease. So that alpha action, vasoconstrictor action can make it worse. So what would be a peripheral artery disease in the digits? Raynaud's would be one. Diabetes, I don't know that you would necessarily, Raynaud's would be one of the biggest ones. If they have bad peripheral vascular disease, that might be a reason to avoid. Okay, bupivacaine, Marcaine, listed there 0.25 and 0.75%. Some of these come, and most of them, almost all of the different agents come with a preservative-free. So if people have had reactions in the past, allergic reactions, it may be what they're allergic to are the preservatives. So a lot of the preservatives would be like metabisulfites, would be a common one, or methylparabens. That is sometimes hard to determine exactly. We're going to talk a little bit about allergic reactions in a minute. Most of the serious toxicities are more related to this drug. So cardiac and CNS toxicities are higher with bupivacaine. It's contraindicated for pregnant women, and be very careful in those who are very ill or debilitated, or the elderly, renal, cardiac, or liver disease. But they are good for longer procedures, because they last a lot longer. If you look on that last page, its duration is about 5 to 12 hours. Can you give them a sense of when you would use that versus lidocaine?
Dental blocks, because you want to.
Marcaine?
Yeah.
Yes. What did you say? What was the other word you said?
The dental block is when you use the Marcaine, and we actually combine the lidocaine and Marcaine together. So that you've got the short acting and the long acting. But no acting, these are close to the carotid, that's what you really do, intraalveolar.
Bupivacaine is more painful than lidocaine, at least from what I've read. They do not recommend using sodium bicarbonate with it, though, to get the pain. It also has maximum dosing, so be aware of that. And you use a higher dose with epinephrine, just like you do with lidocaine. Onset of action is still pretty fast. Duration is much longer. There is a product on the market called liposomal bupivacaine, Exparel. It is a bupivacaine that has liposomes covering it. So it's supposed to be very good in post-surgical anesthesia, and it's about its only indication from what I gathered. Have you ever used it? It hasn't been on the market very long. Carbocadon or bupivacaine is an alternative to lidocaine. So if people tell you they've had a reaction to it, not an anaphylactic to lidocaine, then bupivacaine could be used. Bupivacaine, Carbocadon. Carbocadon is the brand. It's not used very often, but it's an alternative. It's very much like lidocaine. Shorter acting, acts just pretty much is their substitute one for the other. Indications are listed there for local anesthetics, skin surgery, open wound repair, abscess drainage, foreign removal, body removal, vascular access, or lumbar punctures. Choice, again, is going to depend on how long the procedure is going to take you. Need for hemostasis, so that would be whether you use epinephrine or not. Sensitivity to catecholamines, their allergies to local anesthetics. So let's talk about an allergy. So a lot of people will claim an allergy to a cane. Sometimes that's what they'll tell you. So just like we talked about in the past, you've got to figure out exactly what they're talking about. because you do not want to give it to them if they've had like an anaphylactic or type 1 hypersensitivity reaction. So you can use a different chemical class if it's mostly been localized. So if they're telling you that I got blisters right around the place where they injected it, if it sounds more like a local or a injection site reaction, use a different class. You could always use the esters over the amides if that's what they're if they can name the class or what they have. Looking at if it's something other than an allergy, so something would be like a systemic toxicity. Let's say they had a cardiac arrhythmia or CNS adverse effects. That's due to the drug, it's not an allergy. Okay. Vasovagal. A lot of people have it when you inject it. So discerning exactly what the symptoms are takes a little bit of questioning to determine that. If people have had allergic reactions to IV injections of anesthetics, they often can tolerate a topical. The only ones to really be concerned about and to delay a procedure if it's elective would be an anaphylactic or a type 1 hypersensitivity reaction. If not, you need to get someone else in there to give you an opinion as to what can be done or what should be used. Okay, next page. Man, it really is hot in here. Was it hot like this yesterday? It was very hot upstairs. Wow. Medical conditions. Okay, so don't use epinephrine in large wounds. Especially in diseases that would be aggravated by catecholamine, like hyperthyroidism, which is going to make it worse, pheochromocytoma, hypertension, coronary artery disease. So any time where a vasoconstriction or a stimulant would, like with the hyperthyroidism, would cause them to have symptoms. We talked about digital anesthesia in those who have compromised circulation in their feet or fingers. Periorbital infiltration, people have narrow angle glaucoma. Large or multiple lacerations, because of the amount of drug that it would take to inject, would probably near or exceed the maximal recommended. When there are some drug contraindications with epinephrine, one would be lorazepam is a type atypical antipsychotic we talked about with bipolar disease. The ergot alkaloids, those are very vasoconstrictive, so that would be a compounding pharmacologic effect. Beta blockers, you can see why, except unless you're looking at cardioselective ones. Monoamine oxidase inhibitors, why would those be a contraindication? It's how you get rid of the drug. So you're knocking out the ability to metabolize it. Why would the tricyclic antidepressants be there? What kind of agents are those? They're not SSRIs, what are they? They're SNRIs, so they are norepinephrine selective. So it's an enhanced or added effect. Methods to decrease injection pain. We talked about buffering it with sodium bicarb. Warming it up, take it right out of the fridge. Any time you inject cold, most people it make uncomfortable. We talked about with insulin, warming up insulin before people inject it. You can add sodium bicarb to the injections. It's listed there. It will make the drug more unstable. So you should have, if you're going to do that in a clinic, you should have a protocol for that. In terms of drawing it up and how long you keep it would be important. Then other techniques, have y'all gone through these or talked about these? I mean, you've had injections before. You know how they work to get your mind off of it. They talk to you, they're asking you questions. I've never had anybody pinch me, but that's solicitation distraction. Use of a smaller needle. Smaller needles are usually more comfortable than large needles. Slowing the rate of injection. With these, they burn. You've had topical anesthetics before, they burn. Warning patient, this is going to burn a little. Sub-Q will be more well-tolerated. Intradermal. Intradermal, you're usually going to have to use an angle, and you're getting you're under the very top part of the skin, so or right under the top part. So that tends to be a little bit more painful. Smaller volume, so if you can use a higher percent to get a smaller volume is helpful. Again, that 90 degrees is going to put you into subcutaneous fat, whereas that 45 degree will put you in intradermal. Complications, systemic toxicities, the big ones, CNS and cardiovascular. So CNS, some minor ones like makes food taste terrible, or I taste like I have metal in my mouth. Tinnitus, what's that?
Ringing in ears.
Ears. Tingling of the lips, agitation, seizures. Seizures are probably one of the most worrisome of these. Lidocaine is the most common one, and it requires usual life support and then the use of benzodiazepines to treat the seizures. Cardiovascular effects. So you've got bradycardia, decreased myocardial contractility. This is the antiarrhythmic part of this. AV block, vasodilation, ventricular arrhythmias, cardiac arrest.
That's why it's important to aspirate before you inject, so you make sure that you're not in a vein.
Yes.
In that sort of area.
Don't inject into a vessel. Allergic reactions, two different types. A lot of times people will get injection site reactions. They're very common. Any injection usually will give you some type of injection site reaction in people. So it can be the blistering, the weeping. It can be like a contact dermatitis effect. But usually they're localized and they stay right around the area that's been injected. Urticaria and anaphylaxis are going to speak to systemic allergies. Those, if they have that, that should be noted on their chart. They should be told that you have you've had like a type 1 hypersensitivity reaction. They should avoid those drugs. Okay, questions? All right. Anything you would like to say about those?
Add is that okay with that? Interject?
Oh, yeah, absolutely. Absolutely. This is not an area of practicing. Okay, so let's take a break and we'll come back when we're going to talk about EpiPens.